Thank you very much, Shannon, and of course to Ramsey House for giving me the opportunity to share with you this talk. Thanks very much to all the attendees. I know some of you would have had to take time out from your practice, so I hope you find this fruitful. So I chose the topic, Let's Talk Contraception, because it is simple yet can be quite a long consult and can be complex depending on the patient that you're seeing. All right, next. Has my slide changed? Here we go. A little bit of a lag there. Okay, so as Shannon said, I consult in KMC in Cogra, and she's provided my number and email should you wish to reach out with questions or advice at any point in time. So areas of expertise, as Shannon explained, I have a particular interest in advanced pelvic surgery and gynecological conditions. I'm also an obstetrician, so I look after antenates throughout their pregnancy and look after them in the postnatal period as well. Okay, so let's talk contraception. I see a lot of women in my rooms who wish to discuss contraception. So the learning objectives today will be to briefly go through the history taking that's relevant to prescribing contraception. We will talk about the different forms of contraception available and understand the method of action of each. We'll talk about the contraindications and pros and cons of each of the methods. I will then go into the special populations where contraception can be challenging, such as in the perimenopausal period or the epileptic or the mature minor. And finally, I will touch on problematic bleeding when a patient is on a hormonal contraceptive. So the contraception consult may be long. You need to take a thorough history if you don't know the patient. You should have some basic baseline investigations to start off with. There's a fair bit of counselling that will need to go into your consult depending on the patient's needs and past medical history and the complexity of that. And then you decide to prescribe and you counsel some more. Okay, so this looks like a busy slide, but it reflects the things that need to be asked and the things that I want to know when I see them. Generally speaking, I want to know their last menstrual period because this will influence how I tell them to start their pill. If they're suffering from any heavy bleeding or dysmenorrhea or chronic pelvic pain, because then I will tailor the contraceptive to optimize management of those conditions. I want to know why they want to use it. Are they sexually active? Are they sexually active now? Other things like dyspareunia, postcoital bleeding, history of STIs, and whether they're up to date on pap smears. This will define for me the risk assessment for the patient and whether there are any possibly abnormal symptoms that need to be investigated and treated prior to commencement of contraception. I'd also like to know what they've used in the past, if it's worked for them, any side effects, how long they were on it, and why did they choose it. The fertility history, so how soon are they planning pregnancy, if at all, and if they've had any children and how they've had those children, whether by Caesar or normal delivery. And then we need to delve into their past medical history. And whilst this is a very long list, it lists all of the various alerts, precautions, and contraindications to different types of contraception. But the patient's answer may be, I'm well, and I have no medical history, in which case your time has been cut short and you can delve into the different forms of contraception. And finally, could she be pregnant? So how to know if the patient could be pregnant? I think this is pretty simple stuff. You could just do an HCG on the spot, or she'll tell you she's already on her period. But it is important to know, have they had any unprotected intercourse since their last period? Have they been using a reliable method of contraception? Are they compliant? Are they within the 5 days of their LMP? Have they given birth within the last 3 weeks or not? Or are they beyond that? Are they breastfeeding? And have they had a termination or miscarriage recently? So you do need to just exclude pregnancy and any retained products. When we go into the counseling, the things I think are important to cover with a patient are what the medication is, or what the type of contraceptive is, how it works and how long it'll provide them cover, how effective it is, some of the advantages, some of the side effects to look out for. Particularly the side effects are important because if you warn them, then they are less likely to be unhappy that they were not informed and that they didn't know. So things like mood swings, weight gain, irregular bleeding, and sometimes if you reassure them that it is common to experience irregular bleeding in the first few months, they're less likely to come into your rooms fairly soon and anxious. So how to take it and when to start. And then we've already mentioned the importance of having an up-to-date cervical screening test. Counsel them about safe sex and the use of condoms, even alongside of hormonal contraceptives, ensuring that they've had a recent STI screen if they are within the high-risk population, and explain to them what happens should they be less than compliant with their chosen contraceptive method. And I've got OTC there, which is over-the-counter medication. So sometimes they are on things that they don't disclose, particularly medication or herbals that they may have purchased online or from overseas that may interfere with the particular contraceptive that they're on and their efficacy.
Miriam, just a quick question here. A doctor's asked for advice on dealing with Implanon or Mirena irregular bleeding.
Thanks, Marianne. So I do have a slide later on in my presentation where I will be discussing how to deal with problematic bleeding on various contraceptives. Okay, so in terms of investigations, STI screen, cervical screening test, a pregnancy test, a urine test, and baseline bloods. These are the tests that I would do for a patient that you are meeting for the first time and whom you want to exclude an infection or a pregnancy. So what is the ideal contraceptive? It is meant to be safe with minimal side effects, effective with a low failure rate, discreet so that it's only known to the patient to protect their confidentiality. It's acceptable by them, it's reversible and does not delay their fertility should that be something important to them. Inexpensive, long-acting so that if they are struggling to remember to, say, take tablets daily, they don't have to worry about compliance. Ideally, it should provide STI protection, but as we know, only condoms do that. And under the patient's control, so not dependent on a partner that may not be as compliant. But no, there is no perfect contraceptive method. So the things to consider, much of this I've already touched on. The benefits, the costs, the contraindications, the adverse effects, and so on and so forth. So what are the indications for contraception? Contraception is really a method that allows the woman to avoid unwanted pregnancy. And we do need to also to explore the other indications because that may not always be the reason for it. So other reasons may be menstrual regulation. They may be suffering from pelvic pain, painful endometriosis, bothersome fibroids, or adenomyosis pain. They may be suffering from premenstrual syndrome symptoms, perhaps acne or hirsutism. Perhaps they've got PCOS and they need endometrial protection. And finally, endometrial cancer and endometrial hyperplasia are treated by the progesterone contraceptives. But it's a little bit out of the realm of this discussion. Okay, so I do tell patients about perfect use versus typical use. Perfect use of a contraceptive is when the contraceptive method is used correctly all the time, whereas typical use is what generally happens in real life. So it takes into account the patient's error or human error, such as forgetting to take a tablet. So certain contraceptives are great when they're at perfect use, but the effectiveness is lowered with typical use, and this is important for a lot of patients. Only long-acting reversible contraceptives provide the benefit of perfect use because they don't depend on administration compliance. So, for example, you have a Mirena put in, and therefore the perfect use equals typical use. So this is a table on the right-hand side, which just gives you an idea of the difference between pregnancy rates with perfect use and typical use. So, for example, the rhythm method, there is such a huge variation between perfect use rates. So that's the percentage of women that use this method and become pregnant within 12 months. You could see perfect use, you've got a 1 to 9% chance of falling pregnant, but you've got a 1 in 4 chance of falling pregnant with typical use. All these are non-hormonal options. They tend to be less reliable. Male condom, even that's with typical use, it's got a 17% failure rate, can be quoted up to 20%. And then when we move down towards some of the hormonal options, and particularly the long-acting options like the copper IUD, the Mirena, the Depot, these are all fairly effective. The slight discrepancy in the perfect and typical use here is due to the possibility that the patient may be late with having an exchange, or perhaps if it's not correctly situated. And then there are surgical options like tubal sterilization, vasectomy, and so forth. Now, the pill is an important one because up to 32% of women in Australia use the combined oral contraceptive pill. And so you could see with typical use, there's still about a 9% failure rate. Okay, so I've touched on this. There are different types of contraception, and we can categorize them into reversible and non-reversible. Reversible are ones that allow you to preserve fertility long-term, and non-reversible are the ones that are simply just not reversible. You would have to look at something like IVF or a sperm donor. So when we break down the hormonal and non-hormonal options, you could see with the hormonal options, they're all commonly used methods that we're all familiar with, and I'll go through each of those in more detail. And then the non-hormonal includes the copper IUD, all of the barrier methods and natural methods, and sterilization or surgery. Okay, so we'll start with the combined pill because it is the most commonly used method. And along with that, we'll be talking about the NuvaRing, which is also a combined contraceptive. So pills have varying combinations of estrogen and progesterones or progestins. It is the progestogen or progesterone that provides contraception, and this is an important point. The role of progestogen is to provide most of the contraceptive effect through thinning the lining, thickens the mucus of the cervix, and suppresses ovulation. So why do we supplement progesterone with estrogen in the combined pill? There are two simple reasons. The estrogen provides stability to the endometrium through proliferation and thickening of the lining just enough to prevent the irregular shedding and unwanted breakthrough bleeding. So it provides greater cycle control. And it also enhances the contraceptive effect of the progesterone because it inhibits follicular development. Okay, so just going into some of the general points about the combined pill. So we know that there are monophasic and multiphasic pills. Monophasic just means all of the pills, all of the active pills are the same, and multiphasic means that there are 2 or more different formulations of the active pill, so different dosages within that cycle. There's really no evidence that multiphasic is safer or better. Your first line is going to be monophasic. And with the monophasic, you do get different lengths of active pills. Some are 26 days active, some are 24, and then 4 sugar pills, some are 21 active and 7 sugar pills. And that actually has different benefits, and I will talk about that later. There is about a 1 in 5 chance of irregular bleeding with the pill, but it usually settles within the first 3 months. So I encourage patients to remain on the same pill for at least 3 months. And I tell them not to be disappointed from the start if they do need to trial different pills until they find the right one. It's a big disclaimer that I make on a regular basis. Now, the pill has many benefits, which we already talked about: cycle regularity, prevention of pregnancy, helps with pain, with heavy bleeding, but it also reduces the risk of endometrial cancer, ovarian cancer, bowel cancer, and the formation of ovarian cysts in women that are prone to developing very simple cysts on a regular basis with a lot of pain. When we start many of those hormonal contraceptives, the general rule is the traditional starting method, where you have them start on day 1 to 5 of their period, or there's the quick start method, where they start on any day, the day that they are prescribed and administered the contraceptive, and then they are advised to use condoms for 7 days, for the first 7 days until the efficacy of the contraceptive is active. The combined pill is less effective with things like vomiting, the use of antibiotics, medication interactions like liver enzyme inducers, and I do have a slide later on about the use of contraception in epileptic patients, and then the benefits we've already talked about. All right, so what are the side effects? And this is the biggest issue with the pill, and women coming back to say that they're not having a great time. So as Marianne pointed out, there's the issue of irregular bleeding, and I'll definitely delve into that. But other side effects that are worth mentioning to patients is bloating, nausea, headaches, weight gain, breast tenderness, and mood swings. A bit of loss of libido because they get vaginal dryness. They may experience acne depending on the type of pill that you're using, hair loss, bit of vaginal discharge, cervical changes, galactorrhea less commonly. And you could see in brackets, I've put either E or P. O is meant to be estrogen, depends how you like to spell your estrogen, by starting with O or with an E. But essentially, the side effects overlap for estrogen and progesterone for some of them. And for others, the side effects are all secondary to estrogen. And this already gives you a little bit of a hint into what to do if a patient has got a particular symptom and you may wish to convert them to an alternative contraceptive that does not contain estrogen, for example, and therefore avoids some of the side effects that are as a result of estrogen, such as vaginal discharge or cervical ectopia. Okay, so when we talk about the contraindications or precautions of the pill, I think a really useful resource is the UK MEC summary table, which you can print from their website and stick it up on your wall in the rooms, or you can get a printed copy and laminate it, or you can just look it up when you've got someone in front of you and they've got medical conditions and you don't know if a certain contraceptive is appropriate. So the UK MEC categories are very, very useful to stratify the various contraindications and precautions. If a contraceptive is UK MEC 1, so category 1, a condition for which there's no restriction, so UK MEC 1 means it's safe, you can use it. UK MEC 2 means that the advantages outweigh the disadvantages or risks, so use it. UK MEC 3 means that the risks outweigh the benefits. I would caution against using in that scenario. And UK MEC 4 means that the health risk is unacceptable and it's an absolute contraindication. So when we talk about the pill risks, the main ones are venous thromboembolic disease. There's a risk of vascular disease, including heart disease and stroke, breast cancer, liver disease, and also its use in the setting of the postpartum period of breastfeeding, depending on the patient. So very quickly, the pill is a UK MIC4 for all women with a history of clot, regardless of the setting of when she had the clot, any clotting disorders, any multiple risk factors for clots, systemic lupus, antiphospholipid antibodies, UK MIC4. Lesser risks or contraindications, first degree relative who's had a clot at a younger age, or if they're overweight. Vascular disease, so anyone who's got these issues or have multiple risks for cardiovascular disease, so diabetes, smoker, hypertension, dyslipidemia, stroke, particularly if they've got migraine with aura, then they're at risk of stroke. If they have current breast cancer, it's an absolute contraindication. If they've had a history of breast cancer more than 5 years, or a gene mutation carrier, or an undiagnosed breast mass, then they are UK MIC3. So I would still caution and consult their breast surgeon. Liver cancer, liver tumors, gallbladder disease, probably avoid those because it may increase the size of the hepatocellular adenoma or worsen their hepatobiliary condition. If they're breastfeeding and it's less than 6 weeks postpartum, it's definitely not advisable due to the increased risk of clots. Between 6 weeks and 6 months, it's a sort of a relative contraindication, risk of clots, and it is thought to potentially reduce the breast milk supply. And then postpartum, if they're not breastfeeding, you could probably start it from 3 weeks, but I don't do that. So even though it says if they're more than 3 weeks postpartum, it's a UK MIC3, I would just err on the side of caution and wait for at least 6 weeks. So just to give you perspective on the clot risk, you could see that there is, even though there is an increase in the risk of clots with the pill compared to non-users, the absolute risk remains low, and it's in fact much less than the risk in pregnancy. The risk returns to background normal within 3 months of stopping the pill, and the risk is lowest with a lower dose of the pill as well. So just to give you an idea, you could say that, actually their absolute risk anyway is lower than if you were to say be pregnant or be immediately postpartum. So I think these numbers are very interesting. Okay, so which type of pill do we prescribe and to whom? When we think of the pill, it kind of looks like this. There are so many combinations and so many components and dosages. So in order to talk about that, I want to quickly touch on the formulations of estrogens and the progesterones in the different pills. And then we can figure out to whom do we prescribe which. So the estrogen component has predominantly been ethinyl estradiol, which is synthetic, whilst now we've got these newer natural or bioavailable estrogens, such as estradiol, which was introduced in 2 pills in the early 2010 in the form of estradiol valerate, which is in Clara, and estradiol in combination with nomegestrel, it's in Zoli. So we've got Clara and Zoli with the new types of or natural estradiol. And now we've even got a more recently introduced estrogen called estetrol, which is in combination with drospirenone, gives us Nextstellis. So why are the natural estrogens beneficial? Why were they developed? It's because they result in less bleeding and a greater chance of amenorrhea compared to the ethinyl estradiol, less risk of glucose intolerance, less impact on glucose metabolism and liver function, less impact on the clotting factors, the less thrombogenic, and they also have less impact on depression and mood swings. So we know estrogen has a neuroprotective effect on the brain, particularly hypothalamus, hippocampus, amygdala, And it protects against neurodegenerative diseases like dementia and cognitive decline. And so why is it that some pills worsen mood and depression? It's because not all estrogens cross the blood-brain barrier. And so these new natural estrogens, they are more bioavailable and they have a better ability to impact neurotransmitters and areas in the brain that require estrogen in order to provide the woman with good mood and to protect her cognitive function. Interestingly, progesterone is not neuroprotective and in itself worsens mood. Okay, so now we talk about the progesterone formulations. We've had over the years different generations, early generation, third and newer generations. They are different in their VTE risk and in their androgenicity. So the new gen progesterones, the ones that we have been developing, they are more anti-androgenic, so less risk of hirsutism and acne and all of those side effects. However, they have a slightly increased risk of venous thromboembolic disease, some of them, and it's still negligible. And remember, being pregnant puts you at high risk of clots. So the older progestogens like norethistran and levonorgestrel have the lowest VTE risk, but they have no anti-androgenic properties, as opposed to, say, moving down this arrow down the line, cyproterone, drospirenone, all of these, they're less androgenic, and they in fact have anti-androgenic properties, which is very useful in women with, say, PCOS. Sorry, there's a bit of a lag in the slides. Okay. And so now you could see my slide, hopefully. So in addition to the differences between the progesterones with regards to clot risk and androgenic properties, they're also more favorable in terms of the lipid profile and carbohydrate metabolism, similar to the newer estrogens. And also drospirenone has a diuretic effect. So that's useful in some women who particularly suffer from swelling. Okay, so now we go on to prescribing the pill and managing the side effects. So I think I already touched on a lot of this. If we're looking at acne, hirsutism, PCOS, or androgenic side effects, pick a non-androgenic progestogen and you can increase the estrogen. If nausea is a problem, reduce the estrogen, take the pills at night, or change to a progestogen-only method. If breakthrough bleeding is a problem, you can increase the estrogen, and we'll talk about other things you can do. Breast tenderness, reduce the estrogen, change to a different type of progesterone, and consider drospirenone. Headaches, again, reduce the estrogen, change the pill. If they have bloating or fluid retention, reduce the estrogen. So all of the side effects that are predominantly secondary to estrogen, reduce it, or try a different progesterone, or go to a progesterone-only pill or a different type altogether. Endometriosis-specific pill would be something that contains Dionagest. Dionagest has been shown to be really great with endometriosis pain, so something like Valette or Clara. In younger women, I like to use Zoli or Nextstellis because of being a newer generation agents. They have lesser of these estrogen side effects and the newer progesterones that are less likely to result in mood swings. And of course, if compliance is an issue, then you're better off choosing a pill that's got an extended regimen, so a pill that's 24 active pills or 26 active pills. Okay, so the Nuva ring is very similar, except it's a ring that gets put in the vagina for 3 weeks, removed for 7, allows a withdrawal bleed, and then you put the ring back in. You can run the ring every 3 weeks instead. The window is 3 hours for removing it, so compliance is important. You can have sex with it in situ or remove it, then put it back in so long as it's within 3 hours. Provides better cycle control than the combined pill. So if you're having very troublesome bleeding on the pill and you don't know what to do, you can, or you've tried different things, you can try the NuvaRing. Same risks and benefits, but specifically to the NuvaRing, it may contribute to vaginal discharge, expulsion of the ring. They may suffer from vaginitis, or they may just be able to feel it. Okay, so going on to the progesterone only pill, we know that we've got quite a few on the market. The newest one is Slinda, which is drospirenone, and we talked about its benefits. Mode of action, very similar. All of the contraceptives have a very similar mode of action. Thickens the mucus, thins the endometrium, affects tubal motility, and inhibits ovulation. Quick start method would be start straight away and use condoms for 3 days. Otherwise, start with your period, with the period. The side effects we've talked about. It has a more rigorous dosage, has to be taken within 3 hours every day, whereas the pill a bit more forgiving at 12 to 24 hours, depending on the pill that you're on. So when we go on to the mini pill and some of the contraindications, there are not many. So you could see that if they have cardiovascular disease risks, you could still put them on it, but liaise with the cardiologist, or preferably just avoid the progesterone only contraceptives. If they do develop a heart attack or stroke whilst they're on any of these, then do cease it. There is no risk with clots, or you could use it in women with increased risk of VTE. Current breast cancer, still a UK MEC4, so anyone with breast cancer basically can't use any of the hormonal contraceptives. But if there's a history of breast cancer, you may consider it, but liaise with the surgeon or the oncologist. And finally, be mindful of liver conditions that may not be ideal to have when you're on the pill. Okay, so this brings me now to some of the long-active reversible contraceptives. So they're very useful in that they don't require administration too often. By definition, it's any method requiring administration of less than once a month that makes it a LARC. It should be considered as first line. I think it's really useful for everyone to be aware that they have that option, so they are less likely to have to rely on remembering to take tablets. And the advantages are many, and we've talked about all of them. So there are different types of IUDs, first generation, second and third. Initially, the Lipi's loop is one that a lot of you would have heard of. It's non-medicated, it's just physically there. Second gen, then we talk about the copper IUDs, and then third generation are the hormonal IUDs like the Mirena and the Kyleena. So many different types. The ones we have in Australia are the Mirena and the Kyleena in the first and last column. Both last for 5 years. Both have very similar risk profile and side effects. The difference is the Mirena is a higher dose than the Kyleena. The Kyleena is smaller, so I tend to use it in younger women who are nullips, and in women who are just interested in it for, say, contraception, because the Mirena is more effective in regulating cycles and in menstrual suppression in heavy menstrual bleeding. So the Kyleena has less amenorrhea rates. Okay, so now we talk about the progesterone IUDs like the Mirena and Kyleena. Same mode of activity of most of the other contraceptives. Side effects, the most common side effects are frequent or irregular bleeding. And I warn patients this is normal for the first 6 months. They may get some cramps from its insertion. However, many benefits, particularly reduction in bleeding over 12 months. Half of the women will be amenorrheic by 1 year, and it will help with pelvic pain. Some of the risks: falling out, perforation, infection, ectopic. So make sure you screen them, do a pap smear, exclude pregnancy, do an STI screen, and tell them they need to use condoms if they're with a new partner. Now, some of the contraindications, pretty much the same as all of the progesterones. So breast cancer, cervical cancer, current PID, antiphospholipid antibodies, liver disease, liver masses. Now, the good thing about the IUD can be used in nullips and never been sexually active, but placement can be challenging. So I usually give them misoprostol in the rooms, or I give them the option of having it done in theatre under general anesthetic. The Mirena particularly is great to use in women over the age of 45 because you can leave it in situ for up to 7 years. And there is some new data coming out that says you can leave it for up to 8 years. If you're not sure, do an FSH, ideally in women over the age of 50. Do the FSH on 2 occasions, 6 weeks apart. If it's over 30 both times, then you can remove the Mirena after 1 year, or you can leave it until the age of 55. And the IUD can also be inserted within 2 days of giving birth. So sometimes we place these at the time of cesarean section. Otherwise, wait 4 weeks because of the risk of perforation. And I would wait 6 weeks personally. Okay, so copper IUDs, we've got 2 that we know of in Australia. The main reason for the difference is the length of action, because the 10-year copper T380 has got an increased amount of copper in the wire. I think most of this you guys already know. So the main thing is it's not PBS listed. So there is $100 out-of-pocket cost, similar risks to putting an IUD such as the Mirena. Same contraindications, except it's safe in breast cancer. It's also not advised in women with Wilson's disease, copper allergy, and endometrial cancer because it doesn't treat endometrial cancer. It's the only contraceptive that can be an emergency contraceptive, and it's immediately effective. And of course, it avoids all of the side effects of the hormonal contraceptives. If a woman suffers from pelvic pain or menstrual bleeding, the copper IUD is not ideal because it can cause irregular bleeding and it may worsen her pelvic pain. The progestogen-only implant, as many of us know, is the Implanon. The benefits similar to all of the progesterone-only contraceptives. And in addition, it stays in for 3 years, don't have to remember to take tablets. It's maybe preferable in women that don't like the idea of having a Mirena or is at particular risk of PID, STIs, because she's got multiple partners. Side effects are the same. And again, initiate straight away with a week of condoms or put it in during her period. Now, the Depo-Provera is the injection, which is medroxyprogesterone. It's also one of the newer gen progesterones. It's intramuscular, 150 milligrams every 3 months. It can induce amenorrhea, but is associated with irregular bleeding, which can be quite bothersome. The main disadvantages are that it delays fertility for up to a year, and it is associated with weight gain, particularly associated with a decrease in bone mineral density. So this is important in young women under the age of 18 and older women over the age of 50 who are at risk of osteoporosis. So under the age of 18, don't use it. Over 50, should stop it and look at another alternative. It is thought to reduce breast milk supply, so I tend not to use it in those breastfeeding. And it is reassuring to know that in terms of the bone mineral density, it does recover on seizing. But if you are going to use it, just review it every 2 years, even in women between 18 and 50, to see if they'd like to look at a different option. Okay, so I've got a few slides on fertility awareness. I am aware that we're running a little bit short on time. I'll leave these slides aside because they are pretty straightforward, just mainly about, to do with women who prefer not to use any hormonal contraceptives or the copper IUD, who prefer to use something very natural, perhaps for religious reasons or medical reasons, such as, and the different fertility awareness modalities are monitoring their body temperature, monitoring their fertile period or fertile time in their cycle, monitoring their mucus and their the consistency of the mucus, lactational amenorrhea, some of you would have heard of, withdrawal method, male condoms, female condoms, diaphragms, they're all barriers. They all have their benefits. Only condoms protect against STIs. They all depend on the woman or the man to do this religiously. And some of them need practice in inserting, for example, the diaphragm. Okay, so then we talk about sterilization, which are the non-reversible methods of contraception. So female sterilization includes tubal occlusion. We used to do hysteroscopic issue, which is no longer appropriate or offered. It's been banned in Australia because of the complications it causes women. So what we offer now are laparoscopic Filshie clips or a salpingectomy. So these are the Filshie clips. That's what they look like. It's performed laparoscopically. There is a Filshie clip applier. This is the clip. It's made of titanium, and it's applied on the inner third of the fallopian tube, the narrowest portion, and you get one on each side. Sometimes people put two on each side in case it does fall off, dislodge, and then the woman is at risk of having a ectopic. Nowadays, we're offering a salpingectomy more and more because it is believed that a large portion of the high-grade serous ovarian tumors originate from the fallopian tubes. So by performing a bilateral salpingectomy, you are offering them a risk reduction for ovarian cancer. However, it is not reversible once they've had these, particularly removing the tubes in the form of a salpingectomy. So I warn them that they'll have to undergo IVF or tubal reanastomosis or reversal, which has a very low success rate and its own complications, particularly an ectopic pregnancy. Male sterilization is a vasectomy, and I won't go into this in too much detail, but it is an option for men. Okay, so this brings me to special groups. Have we got enough time, Shannon? Maybe another 10, 15?
It's about 1:45, so maybe another
perfect.
10 minutes and 5 minutes for questions.
Okay. Perfect, I can run through that. Okay, so atypical migraines with no aura. If a woman has an atypical migraine, meaning it's a migraine with no aura, she can use all forms of contraception. They're all UK make 1 and 2, so benefit outweighs risk, and it is indicated if needed. However, if a woman's got migraines with aura, then all of the hormonal contraceptives are UK make 4. So with the pill, there is a small increase in the absolute risk of ischemic stroke associated with it in women with migraine with aura. So do consider other methods in women who particularly develop headaches on the pill. I should say not all contraceptives are contraindicated. I'm talking about the combined pill, so estrogen containing. So the progesterone contraceptives are acceptable, but if these women's migraines worsen or they develop aura on the progesterone only contraceptives, I would err on the side of stopping and looking at something alternative. Now, breast cancer is a big one, and you must see a lot of women with breast cancer or have had a history of breast cancer or perhaps a family history. So to summarize this table, you could see if a woman's got a newly diagnosed breast mass that's under investigation and she develops this while she's on the pill, it's a UK MEC3, so best to withhold the pill until this mass is identified. If she already had the mass and it's benign and it's been deemed fine, then she can continue on the pill. All benign breast conditions, UK MEC1, you can use anything you like. any family history of breast cancer, use also whatever you like. So 1 means safe, 2 means fine, 3 and 4, probably not safe. And I hope you can understand what these stand for. So copper IUD, levonorgestrel IUD, Implanon, Depot, mini pill, and the combined pill. Okay, so moving down here, further down along the table, these are the higher risk groups. So carriers of known gene mutations like BRCA1 and 2, they can actually use all progesterone-only options, but the combined pill is a UK MEC3. So if you have the option to use the others, it's preferable you don't use the combined pill in these women. If a woman has a current breast cancer, then definitely none of the hormonal contraceptives are appropriate. Your option is a copper IUD or one of the barrier options or natural methods, or the surgical method, like a laparoscopic tubal ligation. If she's had a past history breast cancer of more than 5 years, then again, all of the contraceptive options with a hormone are UK MEC3. I would still really err on the side of not using them. I did have a patient recently who had a bilateral mastectomy who asked me, I've had both breasts removed, can I use these hormones? I think in these situations, you should just consult the breast oncologist and explore different options and see what is the least risk for her. Okay, so with depression, you can use all forms of contraception. Epilepsy and contraception, the main thing to remember, and it's hard when you don't see this very often, just remember anybody who is on liver enzyme inducing drugs, one of which are anti-epileptic drugs, then some of the hormonal contraceptives that we have at hand are less effective because they do interact with the enzyme in the liver and the metabolism of that hormone. So if they are on one of these medications, the ones that are effective, I think is probably what you should remember, the Depot, the Mirena, and the copper IUD. They're all effective in these women. If you wish to use one of the others, you need to use condoms concurrently for all of them. So the combined pill and the mini pill, as well as the Implanon, are less effective. Valproate is not enzyme inducing. You could use any method. Lamotrigine, same, use any method. And then I've obviously said that the copper IUD is, of course, effective. And finally, small note on the morning after pill, you do need to double the dose of the morning after pill because giving them the 1.5 milligram is also less effective. Okay, so SLE and contraception. We know that with systemic lupus, particularly women on antiphospholipid antibodies that are increased risk of ischemic heart disease, hypertension, stroke, and clots, best to consult. If they've got antiphospholipid antibodies or you don't know their status, the combined pill is a UK MEC4. All progesterone options are UK MEC2 regardless, so you can use any of the progesterone-only options in these women. Copper IUD, of course, is safe. And if a woman has SLE and no antiphospholipid antibody, then you can use the combined pill. So just make sure SLE, check the antiphospholipid antibodies. Anyone with a suspicious connective tissue disorder, just add on antiphospholipid antibody. Now, mature minor and contraception, I don't want to spend too much time on this, but basically anyone over the age of 14 who you feel is a mature minor and has sufficient understanding, they can consent for contraception, but ideally try and involve the parents if they're between 14 and 16. If they're under 14, then they do need a parent or a guardian to consent for the use of contraception. Now, contraception for postnatal women, we have already discussed it, so I will just skim over this. Menopause, we also touched on, so just remember, if they're over 50 and you're not sure, do an FSH on 2 occasions, 6 weeks apart, and check. Then you can stop contraception 1 year later, or you can continue the contraception till the age of 55. Copper IUD can be used until menopause. It's not a problem. Mirena can stay in for up to 7 years if they're over the age of 45. The pill and the depot, they need to be stopped at the age of 50. I prefer even earlier, like the age of 45, because of the risk of bone reduction in bone mineral density and the risk of clots. Okay, so finally, we're up to this slide, troublesome bleeding. Let's skip over what you'd ask, because I know that you'll take a very good history. Now, in terms of just simple measures for managing troublesome bleeding, if a patient is on the pill, just advise them that they should stick with that type of pill for at least 3 months to really give it a good go. It does settle in most women. If it does persist beyond that, you have a few options with all of your hormonal contraceptives, whether it be the Implanon or the Mirena or the combined pill. So you can look at a short prescription of mefenamic acid to reduce the pain and bleeding during their breakthrough bleeding. You can look at tranexamic acid for a short period. Specifically to the combined pill, once they've been on it for 3 months, you could try cycling, so skipping the sugar tablets. You may wish to increase the estrogen component for better cycle control, but obviously watch for the side effects. You can choose a pill with a longer active pill duration. So if it's 26 days or 24 days instead of 21, you have a greater chance of shortening and lightening the breakthrough bleeding. You can consider using the combined vaginal ring instead of the combined oral contraceptive, because it does provide, in some women, better cycle control. If they're on the mini pill or progesterone only pill, you can try a different one, supplement with estrogen, or again, use tranexamic acid or mefenamic acid. And as I said, if we're talking about Implanon, the IUD, the depot, you could use any of the above options. So change to something else, try mefenamic acid or tranexamic acid. You can start them on, say, Provera or Primolute and ask them to remain on that for 3 months until the Mirena or the depot or the Implanon sort of settles in. Usually the troublesome bleeding with the first 3 months of depot is an accurate predictor of what their long-term bleeding pattern will be. So if they have one injection and their bleeding is very troublesome, I would suggest you try something else with the depot. And then you can obviously start them on the pill whilst, concurrently with the Implanon or Mirena or depot for 3 months. Using the pill beyond 3 months is really up to your discretion. There's not a lot of evidence about that, but if you want to keep them on the pill for, say, 6 months and then see how it goes, but usually if the troublesome bleeding does persist beyond 3 to 6 months, then you should, first of all, investigate for causes of abnormal bleeding, particularly if it's new onset, or explore other options of contraception or other dosages or delivery methods. So I hope that answered that question. Thank you very much. I welcome questions. And if you've had to go, or obviously if you have to go, then just feel free to email me or send me a text